Hi, this is Brian Kim. I'm going to share with you case number 141 in the best way to do cataract surgery series. This is a 3 to 4 plus dense lens, and I'm going to show you my typical double chop, cross chop mechanical fracturing techniques. But in this case, I'm going to stop and slow down during those crucial maneuvers for the double chop and cross chop. And I'll go into more detailed explanation of my instrument position, how I'm able to chop the lens, and kind of the subtle nuances of how I'm holding the instruments and making sure I have opposing forces to crush the lens effectively. So I'm using a cotton tip to steady the eye, and this is a corneal marker which will help me to center and size a rexus. Asking the patient to look up and then holding the eye steady. I make a paracentesis incision first on the right side and then the left side. And then I'm trying to stay flat to the iris plane to make sure I get a nice corneal shelf. You can see this patient has some really wild eye movements. And so I'm asking my anesthesia person to give a little bit more medicine to kind of calm down those movements. This is intracameral lidocaine and then intracameral epinephrine and then some dispersive viscoelastic. And this is a triplanar corneal incision. I make a vertical groove, use a cannula to hold the eye and turn it away from me. I place the blade into the deep part of the groove tunnel, and then I enter. You can see this patient has a little bit of unpredictable movements with the eye here. Push some more viscoelastic in, and these are the Inamura cross-action forceps. I'm going in sideways. These are flat-handled forceps, and so you have to make sure you hold the forceps straight up and down in order to more effectively perform the rexus here. So you saw it punctured because it does have a sharp tip. Pull downward, grab the right side of the tear, going around circumferentially. And I'm able to very carefully stay within the corneal mark that I made, which will allow me to achieve a well-centered and sized rexus. So these forceps are really nice as well. Again, compared to the Haldane-Perkar, as I've explained before, these are more like a tong versus a scissor. So there's a little bit more of a vertical profile to it, a little bit thicker profile, but nonetheless, these are also very, very, very good forceps. Let's finish it off and burp the viscoelastic out. And this is the capsular fornix hydrodissection technique. I place the cannula under the rexus edge, contra-incisionally, point the tip down, get a nice wave, point the tip back up, decompress on the left side, sweeping along underneath the rexus edge on the left side, and then hooking the peripheral lens on the right side, and the lens begins to spin. You can see this patient has quite a bit of eye movements, and so far it hasn't caused a major issue, but now with the two-handed technique coming up, it shouldn't be really an issue here. So irrigate the surface of the eye, and then removing the surface epinuclear material. And here we go. This is going to go into slow motion. I'm placing the chopper under the rexus edge, contra-incisionally, making sure the elbow is still right at the anterior capsule plane. I point the phaco-tip vertically sub-incisionally bevel down. I bring both instruments together within the horizontal plane. I'm not going down or up. And as I bring it together, you can see the whitening of the lens fibers. And as I bring the instruments together, they meet in the center. It fractures the lens. You can see that sudden loss of resistance. And you can see there's quite a bit of whitening of the lens material. It makes it a little bit harder to see. And I'm just spreading the instruments apart, side to side here. A little bit more side to side movements, making sure both heminuclei are fractured completely. And here we go. You can see that there's complete fracturing of the two pieces. I place the chopper sideways underneath the rexus edge on the right side. I make sure I go under the rexus edge right there. You can see I went right under, point the tip down, pull it centrally towards the phaco-tip, pull, 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 and then I'm able to fracture the right heminucleus, separating, and now the lens is loose. I use a little vacuum to grab that first quadrant up, and then now I use crushing forces to break the lens down into smaller and smaller pieces, and then emulsify the lens piece. And so that is a double chop and cross chop maneuver. I place the chopper around that second quadrant, pulling it centrally towards the phaco-tip, crushing it against the phaco-tip, and then using some vacuum to grab those little pieces and then emulsify the lens pieces there. The lens is not really wanting to move very well here. And so you can see I'm just trying to figure out what to do next. So I go out with the chopper. I'm pushing some more viscoelastic in. You can see again the wild eye movements that this patient has. And then I'm going to go ahead and hydrodissect one more time underneath the rexus edge on the left side there in the area of that second heminucleus. And then I'm using the hydrodissection cannula to loosen the lens piece up out of the capsular fornix, and you can see I'm able to lift it up and actually hooking the peripheral lens there. And I do this in order to minimize any stress on the zonules. Whenever I see cases being performed and I see really violent pushing of the lens to make it spin, it makes me cringe because I really don't want to put any stress on the zonules. And of course, you can finish the case and do just fine, and it'll be a good case. But what'll happen, 5 years from now, 10 years from now, I don't know. But I do worry that there may be late dislocation of the lens or some zonule-related complication. And so I try not to put any force on the zonules. I try to minimize any torsional stress on the zonules if possible. And so this is why I take the extra step and extra care to loosen the lens up rather than pushing the lens and pulling the lens and creating that stress on the zonules. So you can see here I'm just pushing some viscoelastic into the capsular bag in that left side. And then I'm just, again, hydrodissecting and lifting that lens up a little bit more. And now you can see it's really up and out of the bag. So that's another tip. You can use the hydrodissection cannula, but you can also visco separate the lens out of the capsular bag. And so I'm removing some more of that liberated epinuclear and cortical material. You can see I'm getting underneath the lens using a two-handed technique there, getting under it with the phaco tip, getting across the lens with the chopper, and then crushing it in half. And so again, I chopped it almost like backwards because I chopped the back end of that lens piece, not on the front side. But again, because you're using mechanical techniques to crush the lens pieces, it doesn't really matter how you do it. And because you're using mechanical forces instead of ultrasonic energy, you just have really excellent control of the situation. So I'm using crushing forces again to eat up those small pieces using sparing amounts of ultrasonic energy. I'm placing the chopper around the lens piece there, lifting it a little bit with some vacuum, and then crushing the lens between the instruments, grabbing that next piece with some vacuum, and then again crushing between the instruments. And just continuing those forces of crushing the lens piece into smaller and smaller pieces with mechanical fracturing, and then emulsifying the lens piece when they're bite-sized. By doing it this way, you're really using a lot less ultrasonic energy. And as I've said in my videos, I do notice much clearer corneas, a much more controlled situation by doing surgery this way. Again, I'm crushing the lens into smaller and smaller pieces here, and this is the last piece here. And whenever you're going after the last piece, you want to make sure the chopper is deep to protect the posterior capsule. There's one little nugget right there into the sulcus, that little nuclear fragment. So I was retracting the iris to make sure I can get that piece without grabbing the iris with the vacuum. And now I'm going after the epinuclear material. You can see it's rather stubborn. It doesn't want to come up. And that's part of the reason why I had trouble spinning that lens. So I take the chopper out, push PSS in, take the phaco tip out, and I go in with the INA handpiece. I'm starting subincisionally. You can see how sticky the epinuclear material is. Very, very sticky and adherent to the bag. Again, another reason why I had such trouble mobilizing that second heminucleus. So again, when the lens is stuck to the bag, you know, just pushing and using brute force against the zonules is really not a great technique and a great idea. The zonules will always lose if you really push and pull hard on it. And so you want to just be as gentle as possible when you're doing the surgery. So I'm switching to polish mode and polishing under the rexus edge, removing any lens epithelial cells. As you saw, once I removed all that material, the bag is fairly clean because all of that material was all adherent to the capsular bag together, the cortex, epinucleus. And so once you grab one little bit, the entire thing just kind of all came out at once. Still little bits of cortex there in the subincisional area. The polymer tip really helps me here. And I grabbed the posterior capsule a little bit. You saw it puckered up quite a bit. And it does also, again, suggest maybe there's some weak zonules. And again, in my experience, these dense lenses tend to be associated with weak zonules as well. So another reason why you don't want to exacerbate and stress the zonules any further in this situation. So I'm going to try to polish into subincisional capsular fornix. This is a two-handed technique, so I feel comfortable, even though this patient does have a little bit of unpredictable eye movement. Polishing into the subincisional capsule, you can see it's liberating some of that material there. I'm able to pull it out with the ironing handpiece. And this is a cohesive viscoelastic to fill the capsular bag. And if there's still any remnants in the capsular bag subincisionally, I can always get it with the sweeper here. So again, I'm sweeping the underside of the capsule under the rexus edge, 360 degrees. And again, this sweeper is really excellent. It's angled in such a way that you can get at the subincisional area fairly easily. The paddle is really big, and it does have a sharper edge on the top so that it's really more effective at cleaning. I'm widening the incision with the paracentesis blade, and then I'm going to go in. This is a three-piece lens with the bevel facing to the left. I advance the leading haptic, making sure it goes into the bag. As the optic comes out, I roll my hand so that the lens barrel is turned counterclockwise about 90 degrees, deliver the trailing haptic out of the eye, and then using the Maltman to grab the optic haptic junction and then dialing the trailing haptic into the bag. I go in with the INA handpiece with irrigation off, activate irrigation, going underneath the lens, removing all the viscoelastic from within the bag as well. You can see there was a little bit of that cortical material in the subincisional area. I was able to eat that piece. Reposit the optic back into the bag, polishing underneath the rexus edge some more again. With all that maneuvering, it does tend to liberate some more cortical material. And then switching to viscoelastic mode, removing all the viscoelastic from the anterior chamber. And again, you can see those stress lines in the posterior capsule. Again, that usually indicates there's a little bit of zonular laxity there. And again, it's always in the direction of the haptics here in the three-piece lens. Again, pretty characteristic seeing those stria lines that are going along the axis of the haptics here. Again, so in my opinion, this also, again, confirms there's some zonular laxity. So then I go ahead and hydrate my incisions, and that's the end of the case. So again, you saw double chop, cross chop, mechanical fracturing techniques, and how I'm able to disassemble the lens using sparing amounts of ultrasonic energy, using the two instruments to crush the lens pieces into smaller and smaller pieces, and using high vacuum to my advantage and aspirating those small pieces instead of using high ultrasonic energy. By doing it this way, I utilize less CDE, protect the corneal endothelium more by doing it this way. A very controlled and systematic lens disassembly technique doing it this way. And in my experience, I do have clearer corneas postoperatively, less trauma to the eye, very controlled. And again, you saw this patient has wild eye movements. And even this situation when there's wild eye movements, I have absolute confidence in myself being able to execute the surgery and making sure I don't run into any trouble performing the surgery in this situation. So I hope this was helpful to you, and I thank you for your attention.